Has everyone watched the videos from yesterday? Don't lie. You can tell the truth. Good, so that way you'll be completely lost for today, but maybe not completely. You guys will catch up before the test. You got a couple weeks before that. So we'll have this lecture. I'm going to finish up what I can. The 16, 17, and 18, that's the end of the material for the second exam. I'll finish up whatever we need to for the next meeting, and then we'll have a review that day. So that way we should be able to get through all of the material. Is there any questions before I get kicked off with this stuff? All right, so let's continue on. So we are talking about assessment of risk and benefits in our epidemiologic studies, right? So frequently when we're performing these types of studies here, we're looking to see, okay, what's the risk of a given, say, risk factor or exposure to something, or in some cases we're looking at like preventative measures, right? So if I institute, say, a new smoking cessation program, what sort of benefits are we going to get from that? We can kind of do both with these types of studies here, right? And so again, when we're measuring things like disease frequency, right, we will frequently talk about risk. So for instance, if I look at say smokers and I see the percentage of people that develop lung cancer, right, that would be considered to be the risk. If I'm looking at 100 people and I follow them for 10 years and 10% of them die, the risk of death from lung cancer is 10%, right? So it's just as simple as that. Now remember, we did talk about rates. What was the difference between a rate and a risk? This might be something good to know. So the denominator is what's changing, right? So again, in that example, if I follow 100 people for 10 years, my denominator when I'm trying to determine risk is what? 100 people, right? So it would be, if I said 10 people died during that whatever period, 10 people over 100, my risk is 10%, right? So the denominator is going to be the entire population I was looking at, the entire sample that I was looking at. When you're looking at rates, remember we talked about like force of mortality. We're talking about those nursing homes and how depending on when people died, you would see that it would change a little bit, whether it's beginning, throughout the year, or maybe towards the end. The difference there is that the rates change because the denominator, instead of being the entire sample, what was it? Anyone remember? It was the mid-period population, right? So basically, by using that midpoint, that's kind of like saying an average of the number of people who are at risk for that given outcome that you were looking at, whether it be death or lung cancer, wherever the case may be. So typically when you're looking at population-wide systems, that's why they talk about rates instead of risk. It's just changing the denominator a little bit. The nice thing though is if you're looking at a disease state that's relatively rare, so say like it affects less than, say, 1% of the population, the rates and risk are very similar to one another such that they can kind of be used interchangeably to some degree. If it's something that happens to a lot of people, then you find that as that population changes, the midpoint population changes pretty greatly. It may not be quite as useful there. But let's say we're looking at risk or rates, we can look at the differences there, right? So we talked about things like absolute risk differences. What does that mean? So I have, like, say, two groups and I'm comparing the risk together. One minus the other, right? So you're just looking for an absolute difference, right? And again, this is important when we're talking about, especially like news stories, they like to talk about numbers and they look at these big changes here. And sometimes they can be sort of sort of inappropriate the way they kind of express some of these things here. But we'll look at the differences, how we can do that. Basically, the risk difference is very easy. It's just the risk of, say, the exposed individuals minus the risk of the unexposed individuals. And what the idea there is trying to tell you, like, what percentage of that risk or what amount of risk is due to specifically that exposure, right? So again, if I was looking at lung cancer deaths and smokers versus non-smokers, I just take the risk of death from lung cancer of the smokers minus the risk in the non-smokers. And I'll show you some examples that kind of illustrate that. And the rate difference would be doing basically the same thing, right? Now, if there's truly no difference between the groups, if I was doing an absolute risk difference, what would the null hypothesis be? The difference is 0, right? Because again, 10 minus 10 is 0 at that point. And then when you do these comparisons, you'll have those confidence intervals. Remember, if it crosses 0, that basically would mean that it is not statistically significant, that whatever changes you're seeing between the groups is probably just due to random chance, right? So if we did see a risk of 0, you'd expect it to be no difference between risk. However, for instance, if you're looking at lung cancer deaths from smoking, you'd expect that risk to be probably higher in the smokers, right? So again, you'd expect it to be greater than 1 in those cases there. However, what if we were looking at something protective? Say I introduced like a vaccine, I was looking at the risk for disease. The absolute risk difference would actually be negative at that point, right? Because again, you're having negative risk for actually developing that disease by being exposed to, say, a vaccine in the case there, okay? So again, that's where you may see those negative numbers, and that's totally appropriate based on the kind of comparison they're actually running there, right? So again, it's just as simple as one thing minus the other. We'll get into a little bit more complicated math as we go forward, but again, this is just about as simple as you can make it, right? So let's say, for instance, we're looking at lung cancer deaths in a particular sample here. We have, say, smokers and non-smokers, both in the US and the UK in the year 1986, right? So looking at this, you see the lung cancer death rate for smokers. For smokers in the US was 191 per 100,000 population per year. Now, why do we use this constant multiplier? Make it a whole number, right? You can kind of somewhat, think about 191 people per 100,000 people. It'd be a lot different if you were saying, 0.191 of a person death per, whatever. So that's why you use these constant multipliers. And again, when comparing these, you always want to make sure you're using the same multiplier there. That way you're making sure it's apples to apples, oranges to oranges, right? So in here, you're looking at lung cancer deaths from smokers was 191 per 100,000 population per year, and then in the non-smokers, 8.7. So do you think there would be a statistically significant difference there? Probably, right? So that's a pretty big difference between those two. So you could assume that there would be some degree of difference between those that is statistically significant. Now, again, we mentioned here that these are rates that we're using when we use these kind of population-wide systems. And again, this is still a relatively small number of people being affected by this, less than 1%. So in that case, rates are totally fine as an estimate for risk for these patients, right? They'd be essentially the same. So looking at the risk difference, I was looking at the US and then versus the UK, you would see, okay, 191 versus 8.7. This is basically saying that out of those deaths, that 182.3 of the people that were exposed to cigarettes that died of lung cancer, it was related to the actual cigarette smoking, right? Because you would assume even in the smokers, just like in non-smokers, some people are going to die of lung cancer, that some of those people would be dying of lung cancer anyway, right, even if they were smokers. So you're trying to take out that portion of the risk that's just due to whatever random chance there happened to be there, and then looking at this actual number that's related to that actual exposure. So you could say that the number of people that died from lung cancer due to cigarette exposure was 182 out of that 191. That kind of makes sense? So again, you're looking to see what's that attributable risk there. So that's what we call that when we say attributable risk. What is how do we attribute that to that particular exposure? You do the same thing by comparing it to, say, other rates in other countries, right? And that gives kind of a comparison here. So say in the UK it was 166 minus 7, right? So again, you can look to see that the attributable risk to smoking exposure for these people living in the UK was 159 out of that 100,000 per year. Again, looking at the graphs can kind of help you visualize the data too. So looking at the USA data versus the UK data, you can see here, and again, when we're looking at the difference, we're just looking at the difference in height between these bars here. And so obviously the bigger the height difference, the more attributable risk is being associated with that actual exposure, right? Because if you were to look at people who are exposed to the cigarette smoke, you'd even expect some of them just to have lung cancer anyway. So this 8.7 would probably apply to those people as well, but you're seeing all this additional risk here that is being shown to be associated with that smoke exposure. Now, if you have watched the videos that we posted yesterday, you will know that when talking about causal relationships, can you just say from this information that smoking causes lung cancer? No, right? Because we'll talk about, and when you watch those, and again, it's kind of a nice little preview for your weekend, if you decide to watch these instead of studying for pharm, that you'll see that there may be a relationship here, there may be an association, but that does not prove causation, right? We'll talk about necessary causes and sufficient causes, and then risk factors being a big one, right? We'll typically talk about lung cancer being a risk factor for death from lung cancer, for instance, right? And again, we can then look at the absolute differences in risk, but then we can also look at relative differences in risk. So what do you think would be, how could you describe the difference between an absolute difference and a relative change here in risk? So basically, instead of just looking at the absolute change here between the height of this bar, 191 versus 8.7, just subtracting one versus the other, how do I get a relative estimation of risk? Division, right? So I'll take 191 divided by 8.7. It's basically saying how many times bigger is this bar than the people in the non-exposed bar, right? So how many times larger is that? And we'll look at that data too in just a moment here. So again, another way to look at that is a risk ratio. That's different from an odds ratio. We'll briefly talk about that again because I know we've mentioned it before. But again, if you're looking at a relative risk, if there's no difference between the two, your relative risk would be 1. So it doesn't matter if you're exposed to smoke or not, the relative risk was 1, you get the same amount of lung cancer death regardless. However, if you see that it gets well above 1, that means that there's more risk associated with the exposure. If it's less than 1, that typically means what? It would be less risk, or it's protective in those cases there, right? So if it was like a smoking cessation, I was looking at lung cancer deaths, if it went, say, less than 1, then it would be considered to be protective, right? Now, could it ever go negative? No, right? Because there's a division here, we can't get less than 0 here. So anyway, so that would be what you'd expect to see. And again, it's just 1 divided by the other. Still very straightforward, simple math in our terms here. So looking at this, you could look at the attributable risk information that we had before, and then instead of just subtracting it, we can just divide it out to see what the relative risk. And if you were to actually divide that out, 191 divided by 8.7, note here that the 100,000 cancel out when you do that calculation. So with the last one, we still had, it was 182 or whatever per 100,000. Those cancel out, and this is just going to be 22. So what does that mean when I say 22? 20 times higher risk than it would be if you were a non-smoker, right? So which sounds more impactful, do you think? It was like, oh, we have additional 182 people per 100,000 per year are getting dying from lung cancer death, or you have 22 times the risk of death if you're a smoker from lung cancer. Depends, yeah. So maybe this is a little bit more intuitive. To start thinking about my vocal tics that the mannerisms that have been pointed out to me. Anywho, it's funny because I have no idea where I picked that up from, but now you guys will probably start saying that too. So I've noticed some students will actually pick up our mannerisms, as you'll see. But 22 sometimes is a little bit more intuitive for patients to understand. It says like your risk of death from lung cancer is 22 times higher if you keep smoking. Right? Sometimes that makes it a little bit more clear cut to them in some cases. It just depends on the data you're looking at. If you were to look at it in comparison to that UK data, again, if you looked at the raw numbers between absolute risk differences, it looked like in the US there was more deaths that were associated with smoking than there were in the UK. But when you actually do the division and get the relative comparisons between the two, you actually get 24 here. So in the UK, if you were a smoker, you were 24 times, your risk for dying from lung cancer is 24 times higher. So it appears like there's higher relative risk if you were living in the UK than you were in the US, right? And you could do some comparisons between those and find out if it was statistically significantly different, whether or not that's true. Maybe there's something to that. Who could say, right? Dang, it's another one. But anyway, so I'll show you this graph here in just a moment to kind of show you how we can compare and contrast the absolute versus the relative risk. Is he laughing? His head bobbling. Anyway, so looking at the graph here again, you can look at the how we can compare these two. So again, the attributable risk is just this difference in height between the non-exposed to the exposed, and then when we're actually looking at the relative risk, you're just looking at how many times larger this is than the unexposed bar. Okay, so again, just graphically, that's how we can kind of look at these. And again, how you represent things on graphs is really important, because again, how you choose your scale, how you show all these things can make a really big difference in how people sort of intrinsically sort of interpret that data, right? Graphs are a very good way to lie to people in terms of trying to get them over to your side, right? Depending on how you represent things. So looking at this, although a risk or a risk ratio can be calculated from a case control study, right? Or it cannot be done from a case control study. We instead, if we're using, say, like a case control study, we would use what? We can't use relative risk. So we get into odds ratios, right? So just like we talked about before, we can use relative risk in cohort studies because we know what the whole sample is. We know what the whole sample size is. In these cases, though, where we're doing case control studies, you have to use odds ratios, right? So what are the odds of, say, if you died from lung cancer, if you were a smoker, or again, what was the odds of you being a smoker versus not being a smoker? That's where odds ratios really come into play here. You'll typically find that odds ratios can be a pretty good estimation of risk. So you could do that. However, the larger the percentage of people who are going to be affected by that risk factor the risk tends to change more as you get to a higher percentage here. So if the risk ratio is, say, less than 1%, then the odds ratio is going to be pretty close estimate of that. If it's less than 5, you can probably still use it. So again, this is better for things that happen relatively rarely, so to speak. And so in these cases here, when you're looking at an odds ratio, remember how that's being calculated. So it's the odds of something happening versus it not happening. So the actual denominator is going to be the number of people who did not have that risk factor as that denominator, versus if you're doing a cohort study, that you would be able to just use whatever sample size you have as your denominator, right? Now, what's the benefit of doing a case control study, say, versus a cohort study? Typically, case control studies are what? Retrospective, right? So is that easier to work with? 100%, right? So if I have a database I'm pulling charts out of and I get that information, that's a lot easier to do. It's a lot cheaper, quicker than if I was trying to do, say, a prospective cohort study, right? I could do a retrospective cohort study, which I talk about in one of those videos that you'll be watching. And so you'll get a little bit better idea on how we kind of use those in terms of epidemiologic studies, right? So anyway, so what are some other measures that we can use to show the impact of risk factors, right? So what are some other ways we can estimate the impact of, say, a risk factor or sort of a preventative sort of measure here? And so we'll get into a few of these. And again, a lot of times we use this information for one to educate people, like so how we interpret this data, how we can educate people on the risk or the protective features of certain interventions. We can also use this in terms of like kind of setting priorities in terms of policy making. So for instance, if we can look at information, like say from the Poison Center standpoint, we get funded through the Department of Health, right? So we're funded through the state. However, the Department of Health only has such limited dollars to work with, right? And there's a lot of other people who are probably also vying for that same money. So how do you kind of make your sell, right? How do you show the data such that you show that you're really impactful and that you should be continuing to be funded? All right, that's one example of how we can try to set priorities for that sort of thing there. By the way, we are definitely worth the money because you see huge cost savings when you institute poison centers. Actually, I was on call the other night. I had some good cases that I'll share with you possibly later. Anywho, so some of the differences in the ways that we can kind of measure the impact of risk factors is what we're going to call the attributable risk percent in the exposed. Now, these terms sound a little intimidating, but don't worry, we'll work through them. And then we'll look at the population attributable risk and then the population attributable risk percent. Okay? So we're kind of looking at how we're going to be using all these together. Anyway, so we've already talked about risk difference, which is just the risk of the exposed minus the unexposed. We talked about the relative risk as well, which is just one divided by the other. And we've also mentioned the odds ratio. We're going to work with this a little bit less for our purposes here, just for our examples, but just know that, again, where we're going to use those, mainly for those case control sorts of studies. Getting into the attributable risk percent of the exposed, and these other two we mentioned here. And again, am I going to have you calculate one of these on the exam? Well, you gotta make the argument. No, I'm not gonna do that, right? However, it's important to know kind of what's going into it, right? And so we'll kind of talk more in detail. So you can go back to this. And actually the math isn't all that particularly difficult. It's just when you get in all these variables, you're just like, wait a second, I don't know about this. I don't know about all that, but we'll talk about it, right? So we're gonna look at the attributable risk percent in the exposed. We'll go into more detail on that first, but basically it's just using that attributable risk percent that we already have and just kind of making some modifications to it, right? Basically it's trying to say instead of just saying, okay, how many extra people per year are dying of lung cancer in people who are smokers versus non-smokers, basically it's trying to say like, well, what percentage of that is due to smoking? So, and basically what's saying is, among smokers, what percentage of the total risk for fatal lung cancer is due to smoking? So instead of saying how many extra people are going to be dying from that, you can get it down to the percentage, okay? And so we'll look at the calculations there. And again, basically what you need first is that attributable risk percent in the exposed individual. So you need to be able to figure that out. And so there's kind of two different ways you can actually do the calculation. Again, I'm not going to get super in-depth on this. I just want to point out there's two different ways to do it. Basically, you can either do it with the absolute difference. So if you know that information, you can come up with this attributable risk percent. Or if you have the relative difference, if you have a relative risk, you can still work with that. I'm going to focus just on mainly the one looking at the absolute differences. And so what you can see here is that to get this number, basically you just do your normal risk difference calculation of risk versus the exposed minus the unexposed, and then you divide that overall by the risk of the exposed. This will actually give you a percentage saying what percentage of the total risk is due to smoking. So that's saying this many people extra are dying because of smoking. You can say, well, this percentage of the total risk is attributable to that smoking. And why do we multiply by 100? Yeah, get rid of the decimal and just say, okay, here's the actual number. Here's how many percentage points it is. So in our case, where we're looking at the U.S. deaths there, we can just plug all this in. So again, it was 191 in the smokers. It was 8.7 in the non-smokers. And then overall, you divide that by the total risk in the smokers, right? So it basically gives you, okay, well, we know what the attributable risk here is in the top, the risk difference, and then divide that by the total risk. You can say, okay, well, actually it's 95.4% of the risk of dying from lung cancer was due to smoking. Okay, again, it's another way to show the data, another way to maybe convince someone, hey, maybe we should focus on this. Maybe this is a problem that we should be looking into, pouring more money into. Or if you're talking to an individual patient, saying that, hey, your risk of dying from lung cancer, 95.4% of that risk is due to the fact that you smoke, right? If you die from lung cancer. Not a guarantee, which give you percentages. The other way you could do it is if you have the relative risk, and essentially you just do relative risk minus 1 over the total relative risk. You end up getting pretty much the same numbers there. But again, I want you to know kind of what this value is telling you, not necessarily that you can calculate it, right? Should I say bless me? Next, if we want to look at the population attributable risk, so basically this is a way to extrapolate out data from, say, a certain subset of a sample into the entire population here, right? So when we're looking at population attributable risk, basically what we're asking ourselves is, among the general population, how much of the total risk for disease X is due to exposure Y? So how much of fatal lung cancer cases is due to smoking in this example here. And so basically how we can figure out this is going to be the risk of the entire population minus the risk in people who are unexposed. And again, it's kind of showing the same thing, but instead of dealing with a small sample like we saw in the previous example, we're looking at the entire population. The question is, well, how do you get this number here? How do you actually figure out the total number of people? And I'll show you how we actually calculate that in just a moment. Again, this may not be as useful for counseling individual patients, but it certainly can be a little bit more useful for things like policy interventions, like I said, getting funding for smoking cessation programs and things like that is really important. So in this case here, let's say we have the U.S. data for 1986. So instead of dealing with that subset of male patients like we saw in the previous example, we're just going to be dealing with the whole U.S. population. And what we do know that in the adult male smokers here, it's 8.7 per 100,000. And then we're looking at the risk for the total adult male population. So instead of just looking at that sample set, there's 72.5. So this is including both smokers and non-smokers all being lumped up together, okay? So kind of lumping both of those two together, you notice how the non-smokers are bringing down the numbers for the smokers, such that overall the average is 72.5, okay? So now what I can do is then subtract that out to get that population attributable risk, and it's 63.8. So for the entire adult male population in the U.S., you could say that 63.8 of those deaths that came about from lung cancer were due to smoking. Okay, it's just another way to show the data. This is applying to the whole population here, right? And again, this excess here at 63.8, you're saying is due to that exposure. So what are the number of cases that are caused by exposure? Well, this is how you tell that. So, yes, sir.
How is that superior to the difference formula that was mentioned at the beginning, like the?
So if you remember, we were looking at the absolute risk difference. That was looking at smokers versus non-smokers.
Yeah.
In this case here, you're looking at the entire population minus the smokers. So you're lumping together the smokers and the non-smokers together.
Yeah, I see that. But is the first one not? The first one is just. What's the denominator for the first one?
Whatever your number of people are. So I'm trying to think.
You said 8.7, and then it was like 180 or whatever.
Yeah, that 181. That was just for the smokers that they found. So they found, I don't know what their actual. Basically, when they calculate, that's why they use that constant multiplier there. So when they actually, whatever sample they used, they were able to extrapolate that out and say per 100,000 people, 181 of them were dying from lung cancer.
Yeah.
Right.
I was trying to figure out what's the difference between the 181 minus 8.7 and then 70. I get it's like halfway in between.
Yeah. So in that first one we were doing that attributable risk, that was just looking at smokers versus non-smokers. Here we're looking at the whole population of everyone together, both smokers and non-smokers. So again, it's just another way you're looking at it, and instead of just looking purely at what effects that just smoking have. Now you're looking at the population, like of the people that are going to die from lung cancer in this whole population, how many of them is it due to smoke exposure? That's essentially what we're looking at. Yep. And so you could do the same thing and actually end up getting population attributable risk percent. That's very similar to what we were looking at before when you're looking at the attributable risk percent just a second ago. And you kind of calculate it the same way. You do the risk total minus the risk of those exposed divided by the risk total and then multiply by 100. So again, when you actually multiply this out, you could say here, that when you actually look at the total U.S. adult male population, that 88% of the lung cancer deaths were associated due to smoking, right? They were seemed to be associated with exposure to smokers. Yes, ma'am.
So the other 12% would be those patients that died of lung cancer due to different exposures?
Yeah, so it could have been other exposures, could have just been due to genetics, could be due to anything, right? So basically you're saying that this is what is attributable to this particular case here. In this case here, the exposure was smoking, right? Again, it doesn't tell you, is it cigarette smoking, cigar smoking, is it vaping? Actually, in 1986, it was likely not vaping, but who knows, right? But again, you could say, you run the data again and kind of find similar, maybe the results have changed a little bit. But I'll show you an example how we can kind of play with the numbers a little bit. It kind of shows, well, if we made an intervention, how much change would we see here? So again, looking at this, and this is kind of laying the groundwork for what we're going to be looking at in just a second here. But as I mentioned, this can be used in the policy analysis and also counseling patients, right? So again, if you want to just use it to say, well, you individually, if you're a smoker, here's how much extra risk you have of developing lung cancer. If you want to look at it from a policy standpoint, you say, of the whole population, this many extra people are dying from it. This is why we think we should get funded for this sort of thing. So what's interesting, though, is you can actually estimate the benefit of an intervention, right? So you can kind of monkey around with it. And so to your question of saying, like, well, how do we actually end up getting that total population number here? And it kind of makes sense. Basically, what we can do is figure out the what that whole population per year is, and what they can do is basically look at the weight of smokers. It's not their actual weight, but it's again looking at the risk of death due to lung cancer in those patients times the rate of the smokers. Actually, here's the rate of the actual lung cancer deaths. Here's the percentage of the population that are considered to be smokers. So in this case here is 25%, versus the weight of non-smokers, which would be everyone else in the population, so 75% times that 8.7. So the point here is end up getting, is when you actually multiply this out, you'd see, okay, well, of the total adult male population, that 54.3 people were dying of lung cancer per 100,000 per year, okay? So it's basically just kind of looking together. If you put them all together for the whole population, based on the weights being what percentage of people are actually smokers versus non-smokers, that's how you figure that number out. So then the question is, well, what if I change? What if I had an intervention that reduced the number of deaths, say, by 5%, or reduced the number of people smoking, say, by 5%? And so instead of being 25% and 75%, maybe it was 20 and 80. You can actually see what kind of impact that would have, to see what kind of differences in terms of the number of people dying from lung cancer would be, hypothetically, right? So you're kind of running a kind of a thought experiment here. And so again, you can look to see, like, well, how much benefit would I get from that by making that sort of change? And then we start to get into the financials of it, as we'll see here in just a moment. Yes, sir.
So this is used for interventions. Like, this is just like to see if we can change one of the variables via an intervention.
That's a common way we'll do it, right? Because frequently when we're trying to do these interventions, the idea is, well, what kind of, how much will it cost to actually make a difference? So like for every life saved, what is the cost associated with that, or how much are we saving potentially because of that? And if you can if it makes sense, CENTS, then maybe you'll get that funding, right? So as an example, as I probably mentioned this before, like talking about like state funding for poison centers, like when at some point the people in the health department, I think in Louisiana, they basically said, you guys aren't really making that big of a difference, you're not going to be able to, we're not going to fund you this year. So they shut the whole thing down, and what do you think they found? All those people having limited exposures to, say, Tylenol, or they accidentally take an extra dose of something, instead of calling the poison center for help, they go to the ER. And so what do you think that does in terms of costs? It goes up exponentially, because now all of a sudden you have an ER visit, you have to see a provider, there's all kinds of charges and everything. They may not be experts on how to deal with those exposures. It's a big problem. Once they realize how much it costs them to shut that down, that center, even though it cost money to upkeep the center, it was ultimately a cost savings. They reinstituted it pretty quick, right? So again, this is a way of estimating sort of what kind of changes you might see based off of this. So anyway, so again, looking at this, by getting that population attributable risk, that number we got in the last slide, 54.3 minus 8.7, in this case here, you'd say, okay, well, 45.6 of those deaths per 100,000 per year was attributable to smoking, right? But let's say we have some sort of intervention, let's say we start a program that's going to be reducing that, say, from 25% to 20%. What sort of changes in the overall number of people dying due to lung cancer would we end up seeing there? So if you notice here, based on the last slide, we're changing the weights here. So it's still the same rates. You still assume if you're a smoker, in smokers, you'd have that same exact death rate, because nothing has changed about their smoking habits. It's just the number of people who are smoking. And so this goes from 25 to 20. This goes from 75 to 80. So now you have a lot more, say 5% more people who are going to be non-smokers here. So what do you end up getting? Well, you get this number 45.2. And then now I can compare that to that 54.3 to see, like, okay, well, if I make this intervention, how many cases of lung cancer am I going to be preventing, right? And then you can actually equate that back to, well, how much money is this going to actually produce potentially, right? Because if you don't die of lung cancer, presumably you're around to be more functional, right? You're able to work for longer, you're able to make money, you're able to contribute to society, etc., right? Also, imagine if you have lung cancer, is that a fairly costly sort of disease? chemotherapy and potential hospital care and all this kind of thing, that's a big problem, right? Not to mention a host of other things that come about from smoking, right? COPD and infections, all kinds of stuff. And so this is how we go into actually getting into the economics of things, right? So anyway, so looking at this, we can see that the attributable risk for those smokers, if you were to change the weight of them from say 25% of the population to 20, is now 36.5. So now by subtracting that out, we can see that actually for every year we would end up preventing 9.1 deaths due to lung cancer. And the question is, well, is that economically feasible? Well, how much did the intervention cost? How much would it cost? And then how much extra productivity are we getting out of these 9 individuals here? And so again, it kind of like dehumanizes things a little bit, be like, well, now that you're alive, you can be more productive. Please go and be a cog in society, right? But this is how we kind of work through it, right? Presumably if people are alive and they're healthy, they are probably working, probably contributing, right? So, but then you can extrapolate that out. So that 9.1 per 100,000, let's say for every 100 million men, basically you end up preventing 9,100 deaths per year. That's just in the male population. So when you extrapolate that out to the females, then that could be 18,000 deaths you're potentially preventing per year. Does that sound like a good intervention? Maybe, yeah, probably. Probably sounds like a pretty good thing, right? Depends on how much it costs, right? So we'll definitely talk about that in terms of like number needed to treat and get into all that shortly. So anyway, so this is what goes into what we call cost-effective analysis. And there's people that just go to school and they get their PhDs just in how to do these sorts of analyses here. I know some people, actually one of my coworkers, his wife got her PhD in pharmacoeconomics. And that's basically just looking into how like insurances, how they cover people and what kind of things they'll cover or not cover, what kind of actual impact does it make in terms of life and hospitalizations and all this kind of stuff. So for instance, you know, if you have like a patient with hep C, you know, that could be quite costly, you know, but the drugs to treat it are also very costly, but they're a heck of a lot less costly than, say, a liver transplant. And so that's why they make those decisions to say, well, I want to cover this drug or not cover this drug, things like that. So some extra tune stuff. It's like the wrap it up music at the Academy Awards or something. Just give us a break. We're done. So anyway, so taking this information here, then we can look at the actual cost of it. So we can look at the cost of the intervention, look at the actual costs saved potentially by having these individuals not be sick or not be dead, as the case may be. So for instance, here in the smoking reduction program, if the cost of the program, say, was $1 billion per year, okay, basically that would mean for those 18,000 deaths that we were going to be preventing, it would basically cost about $55,000 per death prevented. Okay, that still sounds pretty expensive, right? Yes, $55,000 is still a lot of money to most people, right? But however, if you were to then extrapolate that out to the entire, say, population at the time was around 200 million of the U.S., basically it'd be about $5 per adult per year. So say maybe tack that on their taxes or something, right? That sounds a little bit more swallowable, right? Perhaps, right? Depends on who you talk to. However, though, if you're looking at the cost of the program, but you only assign it to people maybe who quit smoking, that 5%, then maybe it's about $100 per quitter per year. So again, the different ways to slice the pie, so to speak, in order to kind of see what kind of, what's it going to cost us, who's it going to be costing people. Maybe you introduce this cost in terms of, like, say, taxes on cigarettes or something, right? That's maybe where you recoup the money, perhaps. You know, different things like that could be playing a role here. But again, it's not just the prevention of, say, lung cancer deaths, but it's all the other things that are going to go along with it. So you may see decreases in MI, COPD, different things like that. And so by taking all of that into account, those calculations get quite complicated. And again, they're doing a lot of simulations and things. They do like a lot of simulations to try to figure out, well, if this change occurs, well, what kind of things will we see in the future? So it's very predictive in a lot of cases. It may not always bear out, as the case may be. And so, again, how they're actually defining the outcomes will define how the cost effectiveness actually runs. So that's why it's really important to make sure they have all those data points kind of secured, definitions secured, things like that before they run the analyses. Okay, so when we're trying to calculate, say, the benefits of that smoking reduction program, they basically would look at the positive effects, say, the reduction in lung cancer amounts, and then convert that into dollars, essentially, right? It's kind of an easy way to kind of convert all this stuff over into something everyone can kind of understand. And so, again, calculation of the benefits, you have to look into, like, well, how many hospitalizations are you potentially preventing, maybe in savings to medical care, if you're having that increased productivity, as I mentioned, just due to being alive for longer. And then you then estimate the average cost for just that one case of lung cancer, right? So again, look at the dollar values in terms of one adding a year of productivity onto life versus the number of productive years of life gained from lung cancer, right? So again, if they get it early, then obviously you get a lot more years left alive if you were to prevent that versus if it's maybe something that happens very late in life. So again, a lot of complicated calculations here. So other ways we mentioned we can describe these values here, again, looking at this, whether it be a nutrition change, a behavior change, these are all things we can potentially look into with epidemiologic studies. We've already talked about how we can look at the absolute changes in risk, talk about the relative terms, and then also, remember we talked about incidence density a while ago, remember that? So incidence density would be basically saying if you follow, say, how many cases happen per person per or like 100 people person years, right? So you could either follow, say, 50 people for 2 years, or you could follow one person for 100 years. Basically saying what's the incidence density? That's for something that can happen multiple times. So say, for instance, you're looking at cases of pneumonia. You could say, okay, if I track 10 people for a year, and then they had 6 cases of pneumonia, you could say 6 per 10 person years, right? So it's another term you might want to go back and review potentially if you forget about that. These are just different ways we can look at it. So anyway, so we talked about absolute risk reductions, and again, being a good way to give us an idea of sort of the impacts of our interventions or changes. And so this one's good because what we can get here is a relative risk reduction out of this. And so easy to calculate for the most part, pretty easy for most people to understand. And so let's say, for instance, we're going to have some sort of impact here. So let's say we have something that occurs in the exposed, say maybe 1% of the time, and the unexposed is only 0.4% of the time. If you were to get an absolute risk difference, you end up getting this value of 0.006. So you're like, look at this risk reduction we have here, 0.006, 0.6%. No one's really going to care, right? However, another way you can kind of equate it to something a little bit more understandable is to get this relative risk reduction. And so this is, again, calculated very similar to when we got the attributable risk, like the population attributable risk. You can see here, just basically by looking at that change and then dividing it by the risk in the exposed, you end up getting this. So, okay, well, yeah, it's 0.4%, but actually what we ended up seeing was a 60% reduction in the incidence of this. That sounds a lot better, right? So again, same numbers, you're just kind of expressing it in a different way. So sometimes they say, oh, look, there's a 20% decrease in the risk of lung cancer or heart disease or something like that. It's basically what they're using as a relative risk reduction. And so again here, looking at this, the absolute risk difference of 0.6%. Again, difficult for people to kind of understand or kind of bring about in their mind, but 60% relative risk reduction, much easier for a lot of people to kind of get there. And so we can oftentimes apply this if, say, we're looking at, say, for instance, vaccines. You're looking at people who are vaccinated versus those who are not vaccinated. You could look at the relative risk reduction in the case of, say, measles or polio or whatever you're going to be looking at potentially. That's a common way we'll look at the efficacy of vaccines. So using that relative and absolute risk reductions and relative risk reductions, things like that, we can then get into what we call number needed to treat or number needed to harm. Has anyone heard of this term before? What does that mean? How many people I'd have to treat in order to, say, prevent one case of disease or to cure one person. Why do we care about number needed to treat? Yeah, it tells me how efficacious my intervention is, right? So again, if I have to treat 1,000 people in order to prevent one case of, say, lung cancer with an intervention, does that sound very effective? No, but if my number needed to treat was 2, sounds pretty good. Or every 2 people I treat, one of them is going to have a prevention, right? So this is where it comes into place. It's a handy way to try to tell people how efficacious an intervention is or treatment is. And so basically how we end up calculating that, and it's very easy actually, you just take the absolute risk reduction, which we know how to calculate, risk of the exposed minus the unexposed, and you just kind of invert that. So you basically just take the reciprocal, 1 over that, and you'll end up getting the number needed to treat. So as an example here, if I were to look at, say, using hyperbaric oxygen, I don't know if I told you, did I tell you my hyperbaric joke? I told to an interviewee. I can't reuse my stuff. Anyway, work under a lot of pressure in hyperbarics, okay? That's just saying. Anyway, so let's say that we're looking at the efficacy of using hyperbaric oxygen on leg ulcers, and they wanted to see, okay, well, what's the number needed to treat to get any kind of benefit here? Say they have resistant leg ulcers. And so basically what they found, they had an absolute risk reduction of, say, 0.333, okay? So the basically what you end up doing to get the number needed to treat would just basically by getting the reciprocal of that. So that means that if you were to get that number needed to treat, you'd have to treat 3 patients that have resistant leg ulcers with hyperbaric oxygen in order to get 1 success out of that. Okay. So again, then you can make the sort of conclusions of whether that would be a cost-effective way to do it, whether it's not. I don't know if anyone knows anything about hyperbaric oxygen chambers, but they can be pretty cumbersome, could be expensive potentially. So anyone ever seen like a hyperbaric oxygen chamber? It's pretty cool. The big multi-place ones look like giant tin cans that you have to get to go into. It's pretty interesting. They also have like the monoplace chambers, which is like a big acrylic tube you go into. Looks terrifying, but anyway. Anyway, so the point here is that we can then compare different treatments together. We could look at different types of treatments, compare the number needed to treat. And so would you be looking for a low or high number here? You want to look for a low number, right? So that way you can say, well, I have to treat fewer patients in order to get benefit out of this. And that's one way we can do that. The number needed to harm is just going to be very similar to that. Here, though, you'd be looking at, like, say, an absolute risk increase. So say how many people would have to get treated with this drug before they have an adverse effect, right? It could be one example of that. And you're going to see it's going to be the exact same way to get the number needed to treat. So you just take the reciprocal of the absolute risk increase for those patients there. So that's it for this section. Yes, sir.
So was that the second one, the increase, if you go back to like the other, the 0.006 absolute risk that you had in the previous example, is that you'd apply it to that one, not the first one, because the first one was like a treatment, the second one was like the risk of getting,
This one here?
Yeah, the 0.06,
Yes.
the AR,
Yeah.
or AR of this 0.06. You would use this in the second of those two, right? That you mentioned. Or
I mean the number needed to harm?
Yeah, because it's a risk factor.
Well, it depends on whatever you're saying, the risk of exposed versus unexposed. So again, it could be the risk of survival for 5 years, or it could be, I mean, you can consider risk to really be kind of anything. But what would be the number needed to treat here if I had that 0.006? How would I calculate that? The reciprocal, right? So I did 1 divided by 0.006. What do you get? Anyone calculate that? It's 167. So in that case there, you'd end up having to treat 100 patients or 166 patients in order to see some additional benefit, or maybe harm, as the case may be, if that's what they were particularly looking at. So again, if you're looking at risk increases for a negative outcome, if you're looking for risk decreases, if you're looking for a positive outcome, again, you just take the reciprocal and you end up getting that. It depends on what your definitions are in terms of like what comparisons you're making, etc. Right?
Yeah, I guess I was, because it said risk factor, so it made me think of this as something that harms somebody because it's exposed.
Right, but like risk factors could be a positive thing too, right? So having a high HDL can be a risk factor. It could be something that reduces my risk for, say, cardiovascular disease. Okay. Right? Oh, excess sounds going on today. Anyway, everyone's got their Friday like play mix ready to go. You just had to let that Spotify play, let it rip. Okay. So any other questions before I let you go on a break? Yes, you do have to come back. So I'll see you in 10 minutes.